Next, we have Dr. Nimmo. She is going to be talking to us about insulin. The topic is very interesting and informative. I'm really excited to hear it. So Dr. Nimmo did her medical school, completed her medical school at the University of Tennessee College of Medicine, and then she did her residency here at UAMS and Arkansas Children's. She did a combined med-peds situation, and then did a combined med-peds sort of endocrine fellowship also here at UAMS and Arkansas Children's, and she's been in practice in the Little Rock area, and she's got her own private practice now and is doing really well and thriving, and she's going to tell us about insulin.
Okay, so I'm going to talk about insulin therapy and diabetes. I have prepared this talk a while ago. It's sort of a work with some medical students and residents, and so we've got lots of collaborators. These are all students at one point that rotated through my clinic and a PA student. They're all doctors now, and Dr. Haas is going to be an endocrinologist soon, so I'm very excited to replace myself. Twice actually, Dr. Hester. If anyone has sent patients to me, she can see them. I have no disclosures. Our objectives for today, so we're going to look at the discovery and history of diabetes. We're going to talk a little bit about how insulin came about. We're going to talk about one of the biggest questions I have when it comes to insulin, and that is just why does it behave the way it does? So we're going to look at the chemical structure. We're going to talk about how we start insulin, how we make adjustments, and some prescription tips. That's another question I get a lot of. We'll talk about the interview and medical exam for patients taking insulin. So I'm going to take a quick poll. How many people look at their patients' injection sites? Show of hands. Okay, very important. And then we'll discuss some adverse effects. And I think one of the things about this, why it's very important for this physical exam and when you interview these patients, why it's a little bit different, is because they just think they're supposed to have low blood sugars. They think that's normal. And so they don't come right out and tell you. So it's really important. So history of diabetes, first described by ancient Egyptians over 3,000 years ago. They noticed the polys, so polyuria, polydipsia, weight loss. In ancient India, they found that if ants were attracted to urine, they knew that urine had high sugar content. 3rd century BCE, the term diabetes was first used, and in the 5th century, Chinese noticed the difference between type 1 and type 2 patients. In the Middle Ages, they believed diabetes was a disease of the kidneys, which makes sense, but in the 1700s, an English doctor noticed that patients who had pancreatic injury had developed diabetes. In 1776, so Matthew Dobson confirmed and published that the urine of patients with diabetes was indeed sweet tasting. So we've all heard about this. We thought it was an urban legend. This is real. He also noticed some people died very soon after their diagnosis, and some lived for many years. So then they began to connect the dots, and in 1889, two German physiologists, Oskar Minkowski and Joseph Van Maren, first showed the connection between pancreatic secretions and metabolism of fat. They did a pancreatectomy on a dog, and the dog, of course, developed diabetes. Around the same time, Paul Langerhans, a German medical student, discovered two types of cells in the pancreas. The acini, which he used to function, and an unknown type of cells that look like tiny islands floating among them. In 1901, Eugene Opie, an American pathologist, names the unknown cells the islets of Langerhans, and makes the association between their generation and the onset of diabetes. This is a little slide, a histology slide. I know we grow to love these, but this is our islet of Langerhans here. These are our pancreatic acinar cells. This is a nice little cartoon here of our different cells in the islet of Langerhans. Our alpha cells that make glucagon, our F cells that make pancreatic polypeptides. We've got our beta cells that make insulin, and our delta cells that make somatostatin and collagen. These are our acinar cells that make trypsin and amylase. So before insulin, the prognosis for people with type 1 diabetes was, of course, not very good. Death was usually within a few months after diagnosis. Only effective treatment was a very low-calorie, low-carbohydrate diet. It was very unsustainable. Some individuals were on as low as 500 calories per day, and they felt terrible, as expected. In 1920s, the researchers made an experiment that would lead to the discovery of insulin. So the anniversary of insulin was last year, 1922. So we all know about Banting and Beth. So Frederick Banting was born in Alliston, Ontario. He was the son of a Methodist preacher, and decided to choose a different calling, so he chose medicine. He graduated early, went to join World War I as a battalion medical office. He was wounded and returned back home in 1919. He trained to be a surgeon, opened a clinic in London, Ontario, but his lack of earnings forced him to be a demonstrator at the local medical school. Probably because of insurance, just saying. It was here he reads the latest copy of Surgery, Gynecology, and Obstetrics, and they have a reference to, here's an article of the relation of the islets of Langerhans to diabetes, with special reference to cases of pancreatic lithiasis. So he's very excited about this, and he goes and speaks to Dr. McLeod, and of course with any great discovery, there's got to be some drama. So he talks to Dr. McLeod, who's a Scottish physiologist, expert in carbohydrate metabolism. McLeod was not very impressed, but he says, okay, I'm going to give you a lab, I'm going to give you a research assistant, I'm going to give you some dogs, and 2 months. Okay? To do his work. So these experiments began. Banting and Charles Best, who is a graduate student with a bachelor's in physiology and biochemistry, did again ligating the pancreatic duct in these dogs and then doing complete pancreatectomies in others. The ligated dogs' duct ascending cells atrophy, but the dogs do not develop diabetes. Banting thinks to extract and isolate whatever secretions were produced by the duct ligated dogs, but struggles keeping the dogs that have diabetes, pancreatectomies, alive. Finally, he's able to extract something, injects it into the dogs that he's taken the pancreas out, and the dog's blood sugar gets better. So that's kind of where this all starts. In 1921, Banting and Best presented their findings to the American Physiology Society. Banting was a little nervous, apparently, and so John McLeod, who's the chair of the session, decides to rescue him and help him out. Banting was convinced that McLeod was stealing his credit, and that begins to deteriorate their relationship. McLeod has some connections, so he invites James Pollock, a biochemist, to help Banting purify their extracts. Voila! May 3rd, 1922, McLeod represents the group, makes an announcement that they have discovered insulin, the anti-diabetic agent. Banting and McLeod are the ones that received the 1923 Nobel Prize in Physiology. This made Banting very upset that McLeod was even chosen. Banting splits his prize money with Best, and McLeod splits his money with Pollock. And at the end of 1923, Eli Lilly and Company were commercially producing the first insulin. The first batch had initial concentrations of 1 unit per ml. So if we've all seen an insulin syringe, okay, 1 unit was in there. So if you think about how much insulin your patients are taking, 30 units, 60 units, 50 units, 100 units, a lot, right? Okay, so 1 unit per ml. So the 11th of January 1922, Leonard Thompson, age 14, is the first patient to receive an injection of insulin to treat his type 1 diabetes. So this kid is 14, and a pediatric endocrinologist too. This is not what a 14-year-old is supposed to look like. Okay, so this is when he's getting healthy, he's gaining weight. He lives another 13 years before dying of pneumonia at the age of 27. The first insulin formations were sold in concentrations, and now we're getting better, 3 to 5 units per ml. Short-acting, very highly acidic, just because of all the stuff that is in there. Over time, they improved the processing, and they developed concentrations from 20 units per ml, 80 units per ml in 1925. Banting sold the patent rights to the University of Toronto for $1 for accessibility. Someone will laugh at that. All right, so back to the structure of insulin. This is just a little cartoon. So this is just initially what it what it looks like when it's made. You've got proinsulin where this is cleaved, and then you've got your active insulin right here with your 3 disulfide bonds. And this is what they're trying to copy. Signaling. This is why we tell our patients to please bolus early. Okay, you've got insulin here in the receptor. And all this stuff has to happen before you can get glucose into the cell. Okay, so pre-bolus. Yesterday's insulin, when I was early in my training, I did my peds endocrine training first, and we did the NPH and regular, and there was split mix and 70-30 and 75-25. The medical students that rotate through me have never heard of these. Sometimes I've got a patient on this for expense, and they're like, what is this? And they don't know what it is. I remember calculating 2/3 and then 1/3, and then calculating again into 2/3 and 1/3, and trying to mix it with the NPH and regular. When I got to the end of my PEDS training, which was 2 years, we were using basal, so it switched pretty quickly. So we'll talk about today's insulin. This is why it's very helpful. This is our regular and our end page that I talked about earlier. But this is what we're using now. So these are our analog insulins here. This is plasma insulin levels. This is how they reach a peak very quickly after injection, and then they wear off very quickly as well. This is our basal insulin, where it lasts, it gets into their the steady state here, and then it lasts for this long duration of time. Basal bolus, this is just a little cartoon of what the insulin effect is. We're very familiar with this, and so this is a person who's given a meal. This is how the insulin is secreted. It gets up very high, and then it wears off. And then they eat again, and the insulin goes up, and then it wears off, and up and down again. And then it becomes, when they're sleeping, most of our patients who aren't eating at night, this levels drop overnight and never turn off. So what we're trying to mimic with this injection insulin is just to mimic the same physiologic curve that we want when you've got a functioning pancreas. Okay, insulin duration. So this is just the description. So I think one of the big things is just when you talk to your patients, what term are you using? Quick, fast, rapid acting mealtime. Make sure that you're clarifying that what they're using is different than their long acting or basal insulin. We're going to go through the chemical structures of these different types of insulin. We're going to talk about why they behave the way they do. Again, this is the amino acid structure of insulin. Okay, so our 3-disulfide bonds. Long-acting basal insulin, this is our glargine, our detamere, and our degludec. These reach the bloodstream over a couple hours after the injection, then they lower blood sugars for a very long period of time because they're dispersed very slowly. They deliver these small doses over that 24-hour period or longer. The goal is to suppress gluconeogenesis when they're sleeping and keep blood sugar stable between meals. So this is insulin glargine. This is one of the earliest longer acting insulins. These are the amino acid substitutions right here. Okay. After these are injected into the subcutaneous tissue, this acidic solution is neutralized and it leads to a formation of a microprecipitate. So this is literally a little crystal underneath the subcutaneous. I've seen some electron micrograph pictures of this. It just looks like little crystals under there. I couldn't find that on the internet. This is just distributed very slowly, a very constant concentration in the bloodstream over 24 hours with no pronounced. This is how glargine is supplied. So this comes from Sanity Aventis. It's got the U100 product, vials, pens. You've got glargine from Eli Lilly, glargine from Bioton and Viatris, that was Mylan. So sometimes when I send these to the pharmacy, I'll say, any kind of glargine is fine. You pick. You've also got your, and these are also supplied as pens. The glargine U300, so sometimes I ask, do you know what it means to have U300? And so remember we got our insulin syringe where currently a lot of it is U100. So in that same syringe for these U300 concentrations, there's 300 units in that 1 ml. So they're concentrated, these have different ways that they're prescribed, and I've got a slide. I think they have access to these slides. So if you are a prescriber, or if you teach someone to prescribe on your behalf, there is a quick sheet in there that's kind of your money slide. That's what my students call it, the money slide. It's very important. You want to save that in your phone. Insulin detamere. So this is another long-acting insulin. So you see all these chains are the same. This has a C14 fatty acid chain added to the end. So this is injected. It self-associates and also binds to albumin. So it is released from albumin very slowly, which causes its protracted duration of action. This preparation, and there's some in the packages where there is some data that says a 0.2 units per kilodose versus a 0.4 units per kilodose. There's a little bit of a change in the pharmacokinetics, and again, just clinically, you want to monitor your patient and assess them and make adjustments as they do. This preparation, you 100 units per mil. You've got a 3 mil pen and a 5 pen box, and then a 10 mil multiple dose vial. Insulin degludec, so this is the longest half-life right now of the basal insulins. It's got a mean half-life of 24 hours, lasting up to 42 hours. This one reaches steady state after 2 to 3 doses of administration, and it exists in the pen as a dihexamer, so hexamer 6, and then 2 of them are stuck together. When they're injected into the subQ, it forms a very very long multi-hexamer. And so these little ends kind of break off, they dissolve in these little zinc, and then they get into the bloodstream. And so this is how they slowly end up into the bloodstream, lasting for a very long time. Multiple dosage forms and strength. Again, here, this is the C16 fatty acid chain that causes it to stick together and then slowly end up into the bloodstream. Insulin icodec, this is in the phase 3 clinical trial. This is a once-weekly treatment, for type 2 diabetes. Very, very long-acting insulin. It's got a C20 icosane fatty diacid here at the end, but it's also got these 3 amino acid substitutions, and what these substitutions do is allow stability and solubility, reduce enzymatic degradation, and slows down the receptor-mediated clearance. So it's hanging around a long time, it's stuck in the receptor, and it's broken down very slowly. So taking advantage of these substitutions makes it behave the way it does. Okay, so all of them have the same, all of them have the same basic structure to fit in this receptor, but they've got little modifications that change how it behaves in the body. When do we start? Okay, so extremely elevated blood sugars, uncontrolled on maximum non-insulin therapy. There's a need for rapid control. You've got medications that are causing acute hyperglycemia, or they're not able to tolerate some of the other wonderful medications that we've had. We've talked earlier about contraindications to some of our SGLT2s and our GLP1s. And so if these patients can't take these medications, then we may have to start this one. How to start basal insulin. So we've got treatment guidelines over to the left with their starting doses, 10 units or 0.1 to 0.2 units per kilo per day. For ACE, 0.1 to 0.2. For an A1C less than 8, or 0.2 to 0.3 units per kilo per day for an A1C greater than 8. How to adjust the increments of 5 to 15%. I've seen 10%, and then the ACE says 2 units for a fixed regimen. How often should you adjust your dose? So 1 to 2 times a week, every 2 to 3 days, or every 3 days. And then ADA gives a maximum insulin dose of 0.5 units per kilo. And then we've got our target fasting plasma glucose. Also a comment just with these longer-acting insulin formulations, like the insulin degludec, these need to be titrated a little bit less frequently because they take a little bit longer to get to steady state. And so once they're in there, you can't get them. So prescription tips. So here's your money slide number 1. These are the U100 products. You've got a 10 ml vial, so 1,000 units. If they need more than 30 units a day, they need a second vial. Not all Largene products are available in a vial. If you're using a 3 ml pen, that's 300 units per pen with 5 pens to a box, 1,500 units. If they need more than 50 units a day, they need a new box. The max dose this pen rolls up to is 80 units. Okay, so I get questions about that. How do you know what's the most they can dose? U200 degludec, 3 ml pen, 600 units per pen, 3 pens per box, 1,800 units, 60 units a day. Max dose is 160 units. And then here's for the U300 Largene Solostar pen, the max Solostar pen. This one's greater than 41 units. This one's greater than 60 units. Both of these, this one dials to 80, dials to 160. Okay, please don't forget syringes, pen needles, testing supplies when you start this insulin. Lots of times I will get patients that come back, and I try to get them to come back in a couple weeks, or we'll do telehealth, just check in and see how they're doing, and they said, I don't have any pen needles like that. I'm like, why didn't you call me? And usually they come in the little sleeve, or they just like, well, we thought it was magic, and we just didn't use 2 shots. And then setting titration limits. Yeah. Set titration limits. So this helps to avoid overnight hypoglycemia due to too much basal. So usually when I write a prescription, it's for that first box. So if they're titrating very quickly or they're needing a lot of insulin, sometimes they will run out of that prescription before they're due to get that refilled. So that's why I have those numbers on there. But that way I know if they get above that, I need them to call me because we need to make sure that they're not having low blood sugars in the middle of the night that I don't know about or that they don't know about, or they're eating a whole bunch at night because they're having low blood sugars and they just think they're supposed to happen. They've been told that they need to snack at night. Rapid-acting insulin, these are our Lispro, our Aspars, and our lysine. These are injected before a meal or shortly after a meal. They're absorbed very quickly, enter the bloodstream very quickly. This is what we put in our insulin pumps, and so those algorithms are designed to use the pharmacokinetics to stop and start insulin, to give bolus insulin through that pump, depending on what the CGM is telling it to do. The goal is to match the rapid-acting insulin for a meal to prevent postprandial glucose excursions and keep blood sugars in range. And so, for this lecture, there's a very simple way I talk to patients about this, but this is kind of for us, this is what we want to accomplish, okay? You can call this mealtime, rapid-acting, quick-acting, fast-acting, bolus insulin, whatever you want to call it, but just make sure that you be consistent with the patient. This is Lispro. This is the Lispro AADC. This is the ultra-rapid Lispro biosimilar. The same chain, these substitutions. In the ultra-rapid Lispro that's got microdoses of treprostinil, this is the prostaglandin, you induce a local vasodilation, so it dilates that capillary, and citrate to increase vascular permeability. And so with their studies show that it enters the bloodstream a little faster. These have U100 pens, cartridges, and vial, and this one has a U200 pen for patients that need concentrated. This is Aspart or faster Aspart. This has got, again, your same identical structure. This is your substitution. The faster Aspart has vitamin B3 and amino acid L-arginine, so this increases the speed of the initial absorption, and this aids in stabilizing the formulation. So these are supplied in vials, cartridges, and flex touch pens. Then we've got blue lysine. Here are substitutions. Okay, these come in a pen, these come in a vial, and cartridges as well. When you're starting bolus insulin, you want to assess your patient's comorbidities and what kind of control you want to have. You want to ask about their diet history, you want to ask about their habits, you want to ask about their activity, their job, what other medications they take, how willing are they going to take these injections. I know some of the education has been to start with their biggest meals. You're going to initiate rapid-acting insulin so that you don't give this person who's been on 1 shot a day now on 4, and you slowly have to increase their dose or make adjustments to what their blood sugar to get them in goal. You want to look at their blood glucose monitoring habits. Okay, we want to keep them safe. Are you going to start fixed dose versus carb counting versus meal sizes? This is your other money slide. This is your prescription tip. So if you've got, again, 100 products, more than 50 units in that pen, you have to go, that's 15 units average per meal. Max dose rolls up to 60 units. Lilly, the Lispro product, has a pen junior that delivers 0.5 unit increments. Max dose on that one is 30 units. And then your U200s, if you've got 13 units average per meal, 3 meals a day, max dose is 60 is what the pen rolls up to. If they're about 40 units, you need a new box. And then don't forget more syringes and more pen needles. And then don't forget your testing supplies. How to interview these patients. So this is something that I try to make sure that we're asking all these questions of these patients so that we're screening for everything that could possibly go wrong. Which insulin are you taking is the number one. I can see by the prescriptions, I'll have like 3 prescriptions in there that my staff has generated for me to just sign and send off. And so when they come back, I'll say, which one are you taking? Sometimes they don't know, and I'll say, well, what color is the pen? What color is the sticker? Because they usually can identify that. How much are you taking? Sometimes when I get a new consult, they'll tell me sliding scale, and I'll say, like, okay, what does that mean? Everyone's is different. And they don't understand that. They don't realize that their sliding scale they don't understand it should be unique to them. Are you taking it consistently? Do you skip or miss doses? Sometimes if I'm looking at CGM, I'll say, well, why is your lunch number always not good? And they'll say, oh, well, I go out to lunch with my friends, and I don't want to take my shot. I had to keep it in the refrigerator. I said, well, then you can take it with you. It's okay. And they're very surprised by that. What injection site do you use? Do you rotate your injection sites? If you're doing bolus dosing, do you give insulin before or after your meals? Do you give bolus insulin if you've not eaten? Do you give bolus insulin when your blood sugar is good? Do you adjust your doses for your blood sugars for the meals that you eat? Do you know how to correct your blood sugar for a high, or correct your dose for a high blood sugar? One other question to ask is, are you changing your pen needles? I had someone come in the other day with a baggie full of malfunctioned pens, and he had the pen cap, the needles back on there. When I swapped them all out, they all worked. So he had about 12 pens, and these stopped working at about 20 minutes. And these all work. They need to change the pen caps. Blood glucose control. So how are you checking your blood sugars? Do you carry a log? Do you use your CGM? a lot of these apps for the CGMs, they have an ability to put notes in there. And I'll show them in my clinic, this is where you can dictate your note, and we dictate. Dr. Nimmo is very nosy, and they think I'm reading them all the time, and I'm not. But it helps me know, well, what happened Thursday? What was going on? Why was that day different? Or if they're having a really good day, what was going on that day? Are you hypoglycemic in the middle of the night? So that's a very important question to ask because, again, they think they're supposed to have that, or they don't know that that's not normal. Are you eating a snack before bed to avoid hyperglycemia? So I've got people who eat meals, and I'll see their CGM, and I'll say, why does it go up to 300? Then you wake up 100. Are you doing that on purpose? And they'll say, well, yeah, if I don't do that, I'll go low. And I'm like, oh, we got to change your dose. Do you give basal insulin before bedtime if your blood sugar is normal? So sometimes they won't. And then their blood sugar is high the next day. Do you experience hypoglycemia during the day? How low? What are your symptoms? And then do you have glucagon in case of an emergency? Do you exercise? What is your sick day management? And then in the hospital? So back to the basics. When I was studying for one of my board certifications or whatever, we have this, review book, and the first question is always some funny scenario about this person who's uncontrolled and they're in the hospital and you're talking to them, and they give you all these options to ask. Do they need to go back to see the educator? Do they need to do this? Do you just give up on them? And always the right answer is, can you please witness the person giving their injection? And it just seems so silly and so simple, but that is always the right answer. So I always look at my patients, and this is very important. This gentleman, Douglas, is working. He's got an insulin pump infusion set. Very subtle here. He's real thin. You can feel a little bit of lymphohypertrophy here, so I had to move up a little further. This guy's a little heavier. This one, I don't remember where he came from, but this little atrophy. But I had to have him move his head out here. This lady, interesting. So I was seeing her during the pandemic, and she was telling me her blood sugars were high, so we kept increasing her dose. We saw her I saw her virtually too many times, and so she ends up at the hospital. You can write it down, she's in the hospital. So remember, hospital gowns, right? They're closed to the front, they open to the back. The only reason I got a phone call is because they gave her injection in her arm that we titrated the dose up. She got an injection in her arm, she'd been low for 2 days, and they said, well, we haven't had to give her anything. Well, first thing I go do is look at her belly. Sorry, I look at her belly, she's got pretty significant lipohypertrophy from giving repeated injections in these spots. So you can tell by her skin is dark here, she's got these little fatty subQ deposits. Fat loves insulin, so it likes to hang on to it and does not want to put it into the bloodstream for it to do its job. So insulin calculation, so this is our other nice slide that this is helpful with. These are based on some guidelines from type 1 and insulin pump therapy, but this is what I do like to teach the residents and the students that rotate through my clinic, just because it does give us math, which is consistent, and you can manipulate the math. This is why I like my job as an endocrinologist. I may not have used my calculus or my trigonometry or whatever classes you're supposed to take, but algebra, yes. All right, so when you're type 1 diabetes, if you've got one, and this is an exercise I give my students when they rotate through, and the interns, I love having interns, because if we do this right and we teach them properly from the beginning, they're not going to get this wrong. And I give them scenarios, and I've got just little cards, and I'll give them a scenario, and I say, here's your person, here's your person, here's your person. And it's usually a very stressful, the intern, they're by themselves, they can't call their upper level, they have to move their patient who's in DKA, but clear out of the unit. They need the bed in 2 hours. What is their dose of long-acting insulin? And so they have to come back the next day with their dose of long-acting insulin, and usually it's pretty good. But that is their, and so I tell them, when your patient comes in and you're your intern or your upper level, the first thing you're going to do is you're going to figure out what their dose of long-acting insulin is. You're going to check that out to the T, because always, this person gets moved out of the unit, they don't get their long-acting insulin, and then they end up back in the unit. So starting for type 1, 0.25 to 0.5, some people use 0.3. You divide that half into basal, half into bolus, and then you can split those bolus doses into 3 meals. I'll do this very simply to begin with and just kind of make them eat consistently. If you've got someone with type 2 diabetes, 0.5 to 1 liter per kilo, again divided into half basal, half bolus. So remember we had that titration schedule where we stopped at 0.5 per kilo for the basal dose. That kind of takes this into account. If you're starting basal therapy only, we discussed the 0.1 to 0.2. And then you want to look at the other things. So if their A1C is really high, if their renal function is really bad, if they're on other medications, the age of the patient, what other comorbidities they may have. So insulin to carb ratios is money slide number 3. The amount of carbohydrates that 1 unit of insulin will put away. So this is what the pumps use for calculations. There's a 500 rule, and I've got a reference to this at the end of the slide. 500 rule, I've seen 400 rule. This is just to take into account of the more rapid acting insulin. But you will get their carb ratio by dividing their total daily dose into this number. Okay, it's referred to as 1 over X. If you manipulate this number, you can give someone more insulin or less insulin. So they add their carbs. So if they're eating 60 grams and their carb ratio is 1 to 10, their dose is 6 units. Okay, so I do work with the residents and students with this as well. If my patient says, this is too much, and I'll say, well, how much do you want to give? And they'll say, just 3. So I'll make their carb ratio 20, and then I'll make it to where I want it to be. Until they get used to that, and then it gets to be the numbers that I think are right. If you need to give them more insulin, you would make this number smaller. Okay, so if they needed if they thought they needed 10 units, you would use a 1 to 6 carb ratio, and they would get 10 units for their 60 grams of carbs. Insulin sensitivity factor. So when we talk about correction factors and I interview patients to see what their sliding scales or what the correction factor is, I'll just give them a number. If your number is 100 and you're eating this, how much insulin will you take? If your number is 200 and you're eating the same meal, how much insulin will you take? And so they'll tell me, I take 2 extra units, I take 3 extra units, I take 10 extra units. And I'll say, how does that work? But that way I can figure out what their correction dose is, and then I'll take into account how much insulin they're using. This is the amount of the blood glucose will drop in response to 1 unit. So sensitivity factor, 1,500 for less sensitive to 1,700 more sensitive, divided by their total daily dose of insulin. So the way they calculate this is they take their current blood sugar minus their target, so you can manipulate this, divided by their sensitivity factor, and so you get a dose, and then you add that to their carb ratio, okay? So you can manipulate these, you can adjust this target, this is whatever the patient gives you, and you can just adjust these to fit your patient. Okay, this is developed by Paul Vincent. This is technology for professionals. So this is EndoCalc. This is a calculator for endocrinology. This is on the App Store. I don't know if it's on the Google Store. It's not all kinds of things that we use that are handy for endos. But they do have one here that's got the type 1 insulin pump ratios. And so if you put in their total daily dose, it'll calculate their carb ratio and their sensitivity factor basis. General information should be individualized for patients. So I've got samples in here. I've got 100, I've got 75, and I've got 50. And so this gives me my carb ratios, my sensitivity factors. And then again, I can adjust this if I've got someone with renal failure, I've got someone who's elderly. I can make these adjustments so that I tailor it to their care. Technology for diabetes. So this is just what's on the patient side. So there's all sorts of bolus calculators, personal calculators that you can get on the App Store. I don't have any from the Google phone, but I know there are some that you can get. But you can program in these numbers, these calculations, and the patient puts in their blood sugar, how many carbs they're eating, and then they'll get a dose. Okay, these can track it. Medtronic has an in pen, so they have a Bluetooth pen that talks to the app. You've got your settings in there, and it logs it. These are little log bars here. And so you can connect it to their CGM, and you can track all this data. So you can see if their CGM rises, and then I see their injection. Well, they're dosing after their meals. That makes sense of why that pattern of their CGM was what it was. So adverse events, of course, hypoglycemia. Screen for this. I ask every time. I tell them to please call. Weight gain, how much are they eating to meet the dosage, what they're using. I tell them I can make their blood sugars good with whatever they're eating, but I'm not sure that's the right answer. They can have some edema from fluid shifts and other intolerances. I'm sure we can get this huge list of all the things that people say that insulin does to them. So anaphylaxis, local reactions, hot flashes, arm cramps, and rashes. So other considerations to individualizing treatment for insulin. The goal is for the scheduled doses to be correct and adequately maintain euglycemia. Ideally, the correction factor should just be used to add just a few units because their numbers are good or very close to their target. So you want to look at the age of the patient, their renal function, other comorbidities. Are they at risk for falls? Do they live alone? What are their A1C goals? Should we allow a little bit of permissive hyperglycemia if they've had hypoglycemia unawareness? How long have they had diabetes for? What is their activity? This is if I was finished early, and I don't think I haven't finished early yet. But there's also G factor regular that's inhaled insulin. Any questions?
Inhale insulin?
I have like maybe 2 people on it. Yeah, one's just very needle phobic, and the other just wanted to try something new.
Maybe they did a cut.
Yeah. All right, and then the references are on the slide that you need.
Thank you.
Thank you.
Thank you.